Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Colibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Welcome back to episode 2 of our podcast, Firearm Injury and Gun Violence, Healthcare's Role. Let's jump right back into the conversation and dive into the interesting backdrop of how funding, the CDC, and legislation influences the research for firearm-related studies. What happened to funding, right? Like this was in my brain, this was a public health thing that was researched and it was funded at some point and really, we did a good job about that, I thought, in the same way that we fund lots of different research for diseases or looking for, different curative options. But it does not feel like firearm violence and the research behind it, and even, I don't know what happened to the funding behind it. And I'm curious, one, what happened, if anything at all, and if we're not really researching it at the level that we could be, and that maybe we were at some point, how does that play into the problem?
Sure. So there's a little bit of history here. The Center for Disease Control, way back in the day, back in the 1980s, 1990s, funded this problem and they funded research. And then in the 90s, there was an amendment passed. It was part of the federal government funding bill that goes through every year called the Dickie Amendment. And it said that none of the funds made use for, that the Center for Disease Control gets can be used to promote or advocate for gun control. And so that was sort of interpreted to mean that if a research project or a program that was being offered by the CDC would somehow come to the conclusion that gun control or firearms or some sort of legislative solution to firearms would be beneficial, then they weren't allowed to do that research. They weren't allowed to fund it. So this really created a almost total freeze on gun violence funding across most of the federal agencies for many years, and had a really chilling effect on gun violence research. So for many years, researchers didn't enter this field. If you're a researcher, you have a position in an academic institution, your whole sort of life depends on, getting tenure, which requires funding. So you're going to study something that you can get funded to do. And so, many researchers went into other things that are funded at much higher rates, like cancer and HIV and heart disease, rightfully so, but they had this chilling effect on gun violence research. So now that has really sort of fallen by the wayside over the last couple of years. And so the government is now funding gun violence research. And so the CDC has about 25 million, the NIH has about 25 million, and then the National Institutes of Justice have also been funding research through sort of criminal justice agencies and criminal justice schools for a number of years. So the problem, though, is that, first of all, $25 million is like a drop in the bucket. I mean, compared to the amount of funding that get cancer research and heart disease research. I mean, it's like an incredibly tiny amount of money, and such that the CDC is funding, somewhere along the lines of maybe 6 to 10 projects a year around the country, which is really just not very much. And also, for years, decades now, there's been so little investment that there's no real groundswell of sort of mentors and experts in this field. So, cancer research, for example, is really cutting edge and at the forefront. We're learning so much every day about how to treat cancer, but all of that is being built on the backs of people who've been doing cancer research for decades. Like, we know more in 2020 because we knew a lot in 2015 because we were, learning from what they found out in 2010. But there's basically been almost a 25 or 30-year gap in gun violence research. So both in data collection, we don't really have a lot of data from the last 20 years to be able to look back and say, was the effect of this on this problem or the effect of that on this problem. And there's just not a huge number of people who are doing this work, even today, relative to some of these other major problems.
Wow. So do you, in your opinion, this is a loaded question.
Okay.
Do you think that when we aren't, providing funds and we really aren't doing the research and we really aren't putting, all of our eggs that we could in that basket to make sure that we're addressing something, that it exacerbates an issue?
I do. I mean, I think that, for, I think what you're asking is, does not researching gun violence mean that there is more of it? Can we draw a direct line between the research funding and I think, this is sort of hard to conceptualize sometimes because, how does what's happening in a cancer lab with a bunch of cells growing on a plate lead to better cancer treatments? Well, it does. You develop drugs, you learn more about how the body reacts to those drugs, you do all of those things, and then we get new treatment. But also you learn about prevention. So we learn about how to prevent cancer, things like when is the right time to do a colonoscopy? Well, it used to be 50. Now we think maybe it's 45. And all of this comes together for all of these problems from this public health approach, which is a multidisciplinary and interprofessional approach to a problem. So there's not one solution to firearm injury in the United States. It's going to take multiple facets, and understanding the best way to go about this problem is going to require research. And the research is intended to inform policymakers, right? So whether that comes, those policymakers are people that we elect into government, or those are policymakers are people who are creating hospital policies or city policies or policies that govern, law enforcement agencies and other types of community organizations or agencies. So without data, anytime somebody forms a policy, it's kind of just like an assumption or a shot in the dark. But with data and research, we can really understand what actually does make a difference, what does work. And then we know that that's where we need to make our investment, either in changing policy or we need to invest in programming that works. The colon cancer example is, after a lot of research, we learned that colonoscopies are a great preventative cure for colon cancer. And that then changed the policies in healthcare organizations and insurance companies and what they're willing to pay for. And in some cases, it changed policies on the state and federal level, saying to insurance companies, you're actually required to pay for this because we know that it's so beneficial. So that's where I think, the better understanding the problem and better understanding the potential solutions and testing the solutions in small areas. Does a certain type of violence intervention program work in one community versus another community? And where does a certain type of access prevention for children work better than another type of access prevention for children? Those are the things that we're researching. We look at the data to better understand, and then that informs the policies that either come out of our communities, come into our lawmakers, or come into our healthcare organizations.
Yeah, that makes a ton of sense. And that's a really good comparison, a really good way to frame that up. So let's talk a little bit about how this really plays out, in real life. In real life, we're talking about our real life as healthcare professionals in this way, this multidisciplinary, interprofessional approach. So, I'm curious, what does that look like, and how are, our team members coming together? Is it a matter of an event happens in the hospital and we're just all trained to react? Or, how are nurses, myself, physicians like yourself, pharmacists getting together in this way to address this issue? I'm curious what that looks like, and how do we do that more?
Yeah, I think that some of the data and the research that's coming out has given us tools to better understand what interventions we can do that are both preventative and also supportive when after an incident of firearm violence. So I think, some of the things that we've learned are that organizations that are trauma informed, we're learning all of this about trauma informed care now, and the effects of adverse childhood experiences, of community disenfranchisement, and of the effects of generational trauma on entire populations of people has created situations where we really need to be trauma informed in our approach and need to be sensitive to that. And so that's something that I'm really interested in developing, is how do we use trauma-informed care and a trauma-informed approach? And so I would suggest that everybody goes to the SAMHSA website. It's, I think, samhsa.gov, and you can read all about trauma-informed care. If you don't know anything about it, it's really the best practice in the way that we interact with our patients. So that's something that I've seen healthcare organizations come together across disciplines to say, we as an organization want to be trauma informed, and here's how we're going to bring together doctors, nurses, pharmacists across the entire allied health professions and create a trauma informed organization, because that's a best practice in treating our patients. The other things that I've seen people do sort of in real time is developing various types of prevention campaigns, or using the anchor institution of the hospital to as a vehicle to get prevention information out to people. So what does that look like on a day-to-day basis? Well, for your, you may have a family practice physician who has a group of nurses and some other people from across the hospital who are interested in this, and they work on providing brochures to patients in the clinic about safe storage. Maybe they get a small grant, doesn't take a lot of money, hundreds of dollars even, to purchase gun locks that they distribute in their clinic, so that people, if they want a gun lock, they can have a free one. Maybe it looks like another group of multidisciplinary and interprofessional healthcare professionals teaching their colleagues about how to have a conversation about gun safety with their patients. So patients, we know, because we've researched this, are much more likely to practice safe storage practices if it's discussed with them by their healthcare practitioner than by anyone else. So but most doctors are really uncomfortable with that conversation. They don't know how to have that conversation with their patients. So maybe we provide some training in our hospital or in our organization about how to do that. So those are some of the kinds of ideas that we have, or some of the things that I've been seeing as we've been working on this. And then I think we can't really undervalue the value of community investment. And really, for many years, hospitals have been these sort of walled off places that stand in the middle of rich and vibrant communities with people who are really invested in their space, in their neighborhoods. And the hospital sort of stands in the middle, and people just come in and out of the door. And I think what we really need to do is break down that wall and really recognize that hospitals are community partners. They're not just a tower in the middle of the neighborhood. That we need to partner with our communities. We need to think about how we're investing in the communities that we're working in. And that can be anything from, developing a big program where you're bringing together community leaders and having community advisory boards, or it can be something as simple as asking the cafeteria manager, are we sourcing our food from local vendors, or are we using big companies? Because maybe one way we can invest in our community is to, have a farmer's market, or maybe we can do some of our purchasing from these local places and support our community partners and our businesses. So that, I think, can't really be underestimated, that we need to be breaking down these barriers between the healthcare world and the spaces that they're existing in.
Yeah, I totally agree. And I'm so happy that you said that, because it feels like that. And then even as a healthcare worker within those walls, you feel disconnected from the community that you may very well live in, and that you're there all the time. So I'm glad that you said that. And I'm curious, at your place of employment where you're working, do you have these committees formed, these multidisciplinary interprofessional committees? And, what's that look like? What are the different perspectives, that come to the table?
So yeah, I think that community advisory boards are incredibly important. I think that we have to be very intentional about who we're asking, because sometimes advisory boards or, boards of organizations tend to just sort of give honorific, nods to the right people. It becomes a sort of geopolitical thing. But having true community members that are involved. And then when we're hiring for programs like community outreach workers or community health worker programs, really making sure that these are folks that know and understand the community that they're working in. So there's a lot of these sort of CHW type, just community health worker type positions now, where the healthcare industry is recognizing the value of the lived experience of people from the community in reaching out and providing healthcare. And what that can look like, in the case of firearms, is it can look like violence prevention, but it can also look like community health workers helping people understand their diabetes medications and their healthcare follow-up. And these are really navigators of the healthcare system, but they're culturally relevant to the communities that they live in. So this isn't, somebody who drives in from 30 miles away every day and then tells you when your next set of appointments is and then drives back out again. It's, somebody who says, hey, I see that you need a walker. Like, that place up on the corner, that, Mike's Pharmacy up there on the corner is the place that will have it for you. And here's your voucher. How are you going to get over there? Did you know that the number 2 bus goes there? So, it's really much more community relevant. And I think that recognizing the value of those individuals and bringing that in is really, really important. And so that's, I think many of this is just in its infancy right now, but that's a lot of what I'm seeing that this sort of ends up looking like when we talk about community investment.
Yeah, absolutely. And, there's a parallel here that I'm seeing, right? Like the community, the actual community, the people that are living there and, breathing there and eating there, and their whole life happens in the community. But then I think about the inside the hospital, right? The multidisciplinary community, like we are the community in there as well. And it's kind of both in this way. And it's fantastic that we have representation from all of these different fields. And I'm curious, from your perspective, what do you think the benefits are in having this type of shared committee, we're all in it approach versus, let's say, just the nurses are working on the firearm violence committee, or just the doctors are doing this, or we got one pharmacist on, what's the benefit of all of us getting together and having these conversations and trying to solution?
So I think that what we know, this has been proven in business, right, over and over again, is that diversity matters, and diversity brings all kinds of perspectives to the table. And that is so valuable. And, business and industry and, the Googles and Amazons of the world have been recognizing this, for a while, and recognizing diversity as an important pillar of building their businesses. It's just good business practice. And so that is exactly the same in the hospital, right? So, and it may be diversity in terms of diversity of individuals by, gender and ethnicity and background, but it's also diversity of thought from the different disciplines. I didn't go to nursing school. There's a lot that is taught in nursing school, and there's a lot that nurses experience that I just don't understand because I don't have that lived experience. And so that lived experience is incredibly valuable to the conversation. And so is the lived experience of all of the different people in the system. So diversity doesn't always look like what we typically think of as diversity, but it's also diversity of thought. And, we've learned so much, even just in the group of physicians nationally who are working on the gun violence issue, is bringing in the perspective, for example, of physicians who own guns versus physicians who don't, and physicians who work in rural settings versus those who work in urban settings. And so we're all seeing different things, and we all have different stories that all matter. And we're all bringing that perspective. So even that within the hospital, multidisciplinary is always going to bring that diversity of thought that's necessary to really take it to the next level when it comes to solutions.
Yeah. And that thought and those perspectives, one of the things that I remember learning in nursing school, what feels like a bajillion years ago, is you always have to check yourself at the door, right? There was this kind of the old adage, like you check yourself at the door before you walk in there and start handling patients and caring for patients and families, whatever's going on, know yourself, right, first. And this is obviously one of these topics, these events, these themes. It's a big deal, and it elicits a lot of emotions and a lot of feelings. And depending on just your own perspective, how you feel about firearms, how you feel about the gun violence that we hear about, could certainly make a difference in your ability to participate in a committee or to help to solution in that way. And I wonder how that shows up in real life. And is that a conversation that we're having rather in hospitals, around, hey, like before you join this committee, before we come in here, should we do a gut check on our own selves and think about, how do I feel about firearms in general? How am I affected by firearms? What's my own experience? And can I contribute? Do you think that that's something that one is happening and that we should include in the conversation? Sometimes it feels like we all want to help, and that's fantastic. Like we all want to help and jump in. But this feels like one of those moments in nursing school that I feel like my professor would have said, check yourself at the door before you walk in there.
Yeah. Well, I think that checking your emotions at the door is important when you want to look at data and be objective. So as a researcher, I am passionate about this problem because of what I see, but I also know that I can't let it guide me to a conclusion that doesn't exist simply because that's what I want the data to show me. You have to let the data show you what it's going to show you. So in that sense, there is a check at the door. I do think that, when you're working in a multidisciplinary setting or a committee, or you're trying to bounce ideas about what you want to do, I think that you can bring your lived experience to that table. You just have to do so in a way that's thoughtful and respectful of other people's lived experience as well. Yeah. And I think, like a lot of, I've heard a lot of people say over the years, non-gun owners don't have a voice in this like, what do they have to say about the problem? Or, gun owners shouldn't have a say in this problem. And I think actually both perspectives are really valuable in understanding that we can come together over being anti-bullet hole. So we don't have to be, it's not about the gun or the anti this or anti that, but I think we can all agree that we should have a world where children don't have bullet holes in them. And so let's start with that and then go take it from there. And I think in that way, the multidisciplinary sort of authentic self conversations then become really valuable, because if you exclude gun owners from that conversation, you're not going to come up with a valuable solution. And if you exclude non-gun owners from the conversation, you're also not going to have a valuable solution. So it really is about coming together and deciding that we want to be safe, that we want our children to be safe, and that we as a society should not accept this unacceptable level of injury and death in our society when we know that it just doesn't have to be this way.
Absolutely. And, something that you mentioned earlier, I just wanted to piggyback on because you've given a ton of great information around even like what we can be doing on our feet in our settings where we're our place of employment, and within our disciplines and within our multidisciplines to really address this issue and get smart about this. Dr. Bonnie, can you give us a little bit more granular details on what these community-based interventions might look like for firearm violence?
Sure. So one of the big things that hospitals have been working on over the last several decades, actually, is this idea of hospital-based violence intervention. And so this doesn't necessarily mean gun violence. It can mean any kind of interpersonal violence. But the idea is that when people are in the hospital and are a victim of violence, there's many reasons why this may have happened to them. And many of them are related to the social determinants of health. And so if we can help our patients mitigate those social determinants of health, then maybe we can prevent them from becoming re-victimized or being a victim of violence a second time.
For sure.
So believe it or not, many of the patients that we've seen in our emergency rooms have, some of them have been shot before and are coming in shot again. And some have been the victims of other types of interpersonal harm and are coming in either shot or stabbed or assaulted and being re-victimized over and over again. And so what we've done is we've helped our community organizations bring individuals into the hospital, or we hire people into the hospital who then help those patients understand and mitigate those social determinants of health. And we use that moment in the hospital to really create sort of like a fork in the road moment for our patients. So where this comes from is kind of some of the cardiac literature. For example, if I have maybe an uncle who is, overweight and smokes and has high blood pressure, I can say to him, like, you need to take your blood pressure medications and lose some weight and try to quit smoking. But when he's in the hospital having a heart attack, that's the moment that everybody's ready to eat better and stop smoking and start taking their blood pressure medications. And so the same sort of applies for violence, as we can say, like, look, if you, are not in a safe living situation, if you haven't finished school, if you're not, with stable employment, if you don't have an identification, if you have certain tattoos that maybe you've gotten in the past, that makes you at a higher risk of becoming a victim of violence. But we can help mitigate some of that. We can help you find safe housing. We can connect you with job employment agencies or with educational resources. We can do tattoo removal. We can do all of those things to make sure that you don't, we don't see you back here in this emergency room in this place again. And we do all of that with the assistance of community health workers and community informed and trauma informed individuals. So people who really can deliver that message in a way that provides that patient with a mentoring relationship, with this additional support that they need, with help navigating all of these community resources. It can be very, very difficult to navigate all the resources that are available to people, and then try to do it on top of recovering from an injury. And it's almost impossible. So by giving people that extra help through these community health workers, through these navigators, we can help mitigate these social determinants to help improve and reduce the chances that somebody is going to end up in these hospitals again. And this is actually a data-driven approach. So people have been researching these programs for the better part of 2 decades now. There's some really good organizations that have been doing this a really long time and have proven that it works over time by tracking the patients and tracking their hospital data. And there's even a national network of organizations that are doing this work. It's called the HAVI, the Health Alliance for Violence Intervention. They have a website. You can check it out. And this is a national organization of hospital-based violence intervention programs that are working with community-based violence intervention programs to build these models that make sense to help people after they've been violently injured.
That's really fascinating. And it was small but powerful little changes that make such a big difference to really equip people with. That's fascinating. Thank you for sharing that. Wow, we can clearly see how interprofessional violence intervention programs and partnering with the community can really make a difference to help prevent or address firearm injury and violence. We don't have to wait for a terrible incident to happen before we can make a difference. Prevention and partnering with the community is a great way to decrease injury and encourage better outcomes. Thanks for joining us for episode 2. We wrap up our conversation about firearm injury with a short episode 3, where we discuss supporting healthcare workers and more about intervening at the community level.
This podcast featured content from an accredited CE activity provided by Colibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.